if you really take a step back and you go back to the root of why you did anything,
Mm.
like why did I do this company? Because I recognize that we didn't have a way to understand addiction. We're guessing. There's a gap in care. We're saying maybe this person who's coming into my office who's going to get radiation oncology, maybe they have an addiction, maybe they don't. I don't know. Here's the medication. Good, thanks. It's a guessing game. In this day and age, why on earth would we guess at prescription uh, narcotics that are prescribed in this way? Why would we guess?
Welcome to the Medical Sales Accelerator podcast. I'm your host, Zed Williamson. The technology that comes out of medical device is always absolutely fascinating. And then when we are trying to go to market and make things happen, it can feel like we live in a world of no's. Ideas get shot down just because someone decided in the past, well, that doesn't work, so don't even focus your time there. It doesn't feel like the healthiest way to run business. And that's why we're speaking with our guest today, James Piacentino, CEO of Thrive Genetics. They combine genetic and behavioral insights to proactively evaluate and manage addiction risks when tailoring prescription regimens. James, thank you so much for joining us today.
Thanks, Zed. Honor to be here. Appreciate the time.
Absolutely. So I'm really fascinated with your company. And I love coming across organizations that have found these niches that are so powerful and meaningful to humans, because that's what we're actually all here for in this space. If you don't mind, just let our audience know, what's the origin story of Thrive?
Yeah, so it's I always tell people, I said we're in our early stages, 3 years or so, and this is something that's been a part of my life since I was a kid. To be honest, my father was an alcoholic. As a result of in 1982, he was in a horrific car accident. He had several spinal surgeries, went home with pills in his hand, and unfortunately, he started to mix that with wine to numb his pain, and he became a full-blown alcoholic, eventually passing away from the disease. And this was just like one of those very impactful moments as a child. I was in second grade. He passed away when I was in my 20s, so it was a very long,
Mm.
traumatic process. And I tell people a big part of this company's soul isn't just looking at how do we stop and get in front of addiction. It's how do we stop the generational trauma that occurs when you're a family of four. It's not just the person, it's the other three members. And then if you exponentially look at the amount of people that are impacted generationally from one person's actions, it becomes a multi-billion-dollar problem. It's hitting our GDP. It becomes a very emotional complexity in families that is a sleeper. So when I went through that as a child, I always wondered, is addiction in my genes? My grandfather was a gambler. My father was an alcoholic at this the situation I just mentioned. When you start to think about generations, does it skip? I don't have an issue. I'm not in recovery. Never even felt like I had an addiction pull in any direction. So is it skipping me and going to my kids? That was the question sitting on my shoulder for 20, 30 years. So I got to a point where I said, you know what? I think I've been in tech for 25 years at that point, and I said, I'm gonna take this ball. And I had a couple, really interesting people I met, and I was introduced to Dr. Danielle Dick at Rutgers Addiction Research Center, who actually had the science that understood the genetics and the behaviors of addiction. And I said, well, with my tech background in life sciences and healthcare, over 20 years, let's partner up. We'll build a business around your research. And I was pleasantly surprised to find out her research was 10 years and over $30 million invested from the NIH in building her science to identify the genes and the behaviors that identify addiction risk in humans, all sitting in the research lab. So
Wow.
together we went in on this company, built it out from that idea. We built the platform and started to, bring it into hospital systems. That's where we are today. But the origin story is really important to note that this is something that comes from over 10 years of research before we even started the company. And it comes from a deep rooted place in my soul, to be honest, that I feel we can reach billions of people, not the addiction situation, but billions of people throughout generations by getting in front of this type of problem.
I think it's so important that you're thinking of it that way. It's easy to zoom in super tight on an issue and kind of take a step away from what the ripple effect is. And like you said, the ripple effect is not, it's not like you tossed a small pebble into a pond ripple. It's a, destroying wave that can happen.
Yes. And that's what we saw together. So Danielle is actually a tremendous researcher and scientist. You can look her up. And her work is, unprecedented over 20 years. And to be able to partner up with her and have a clinical validation, scientific proven papers behind this, be able to get up every morning and work with my advisors, investors on bringing this to a market is like, I never said I had a dream come true to be this. Probably would have been a musician or hockey player, but this is darn close, man. Yeah.
Well, when we think about, for the audience to truly wrap their head around it, can you walk through the narrative of the utilization of what you guys are doing? And what I mean by that is I want to imagine a patient, imagine a scenario like they're having some kind of procedure, and we know that a certain percent, if treated with opioids have a higher likelihood of addiction. Where do you come in, and what actually decisions are driven by the technology?
No, that's a great question. So if you think about a traditional example, so head and neck radiation oncology is a very painful area. Something like a spinal neuro situation, very, very painful. These procedures are fairly short and a lot of pain. So they require pain medication, typically some of the strongest that are in the market. That's really a really great place to kind of give you examples. So let's say someone who goes in for head and neck cancer, let's say they have human papillomavirus and they're getting the cancer literally scraped and burned out of their throat. The first meeting, the procedure is typically just around close to 3 months, the process for the patient. So the patient walks in the first meeting, they're going to do their blood work, and they're going to go through the derived genetics, behavioral and genetic test, which genetic is just your basic spit in a tube. Nurse practitioner takes it, sends it off to the lab. In a couple of days, it comes back, hits our back-end system. At the very moment they're sitting there, they're doing a 25-question survey with the nurse practitioner. It takes about 5 minutes. That gets the behavioral data. So the behavioral data then goes to the back-end system. When the genetic part comes back, it's just the full genome. And then our algorithm looks for the 4 or 5 clusters of genes for addiction, brings that genetic data forward, behavioral data forward, puts it together, and gives an addiction risk score. That is a one-page output PDF in the inbox of the physician. Doesn't necessarily go to the patient. It could, but usually doesn't. And it goes to the physician to use as a data decision support tool for their medication prescribing activities. Because typically in that first meeting, one of the questions is okay, this is going to be a high pain procedure. Do you feel comfortable with certain medications or not? Many patients, greater than 50% of the patients, will say, I do not want an opioid. I do not trust it. The problem with that statement is if you're not taking the medication, the actual success of the procedure is at risk. So instead of a 3-month procedure, it may turn into a 5 or 6 because you're not dealing with the pain. That increases mortality rates. It really defeats the internal KPIs for them to be successful. And then, not to get real numbery on you, but there's multi-million dollars of costs that are really following that 3-month, 5-month, 6-month. It's not like the hospital's making more money because you're there, because they're actually not. It's actually a cost. And for those who have an addiction propensity or high, and say, yeah, I'm going to take the test, and they have a high risk, it gives the physician an opportunity to introduce a different precision medicine plan. Maybe they partner with a pharmaceutical company to bring in a product that's a little bit more supportive of that person's scenario or situation, and it creates a better, healthier path. The goal is really to come out of that 3-month procedure in 3 months, to not create an addict, because up to 20% of the patients that go in for these high intense pain procedures and have these products, up to 20% from an opioid perspective come out with an addiction issue. So when you really look at the numbers, it's actually incredibly costly. Some systems are suffering up to $100 billion loss a year, these large integrated systems, in these costs. So That's the storyline of a use case, I would say, in
Yeah.
a very short, brief couple sentences, if you will.
Yeah. And I want to make sure the audience wraps their head around some of the things you talked about there, because,
Yeah.
so if a patient is going in for this procedure that you used, the pain is so intense that if they say, no, I don't want to use an opioid, they can't deal with the pain at a level to be able to do the procedure as fast as they should. Am I wrong? Or is that?
No, you're on the right track. If they say I don't want the product, and I usually say this, and I'm sorry I skipped it, but if you're asked to usually come in on a Tuesday, and then literally they're burning the cancer out of your throat, and then you're saying, okay, I'll be back next Tuesday for the same procedure. By Wednesday night, you're like, I can't
Through
sleep, I can't
this. Yeah.
eat, it's just horrific. What do I do? Right? So we have a pain app we're building too that does pain management to support that process as well. I don't want to go too far with it, but yeah. So you're right, though. You're on the right track.
Okay. And then so with the power of what you're doing is right now there's someone raising their hand saying, I don't want it. And that's out of fear, because that's 50% of people when we know that only 20% have the likelihood of addiction. So you're also, that idea of precision doesn't necessarily mean it's not opioids. It's just precision, which means it's tailored to the person, which this is a lot of the problem with healthcare is things that are not tailored to the person.
Yeah, and I think that's a great point. So being a decision support tool for the physician, the goal is to, yes, and in fact, this is actually part of the work we're doing with this one large hospital. They actually have a product they use, and I don't want to name product names, but they have a specific product that they use, and they've had some pretty good evidence with it as an alternative. Is it the greatest decision? No. But what it's going to allow us to do as we continue to move forward with them is to find other products that can support the situation. And I think that's really all we're looking for, right? Is that, like you said, it's a percentage that's going to say, okay, we need to take a precision approach. If you go to certain systems, and I'm not sure the statistic exactly, and I don't want to misquote it, but it's extraordinarily high that they don't ask any questions. They just say, here, take this. The number is it's a staggering number, and I don't want to
Sure.
misquote, but it's a staggering number. And you go, wow, they're really not even doing anything with precision. So what this does is it puts data behind the decision for the physician and for the patient, because the patient might come in. I spoke with somebody yesterday in the podcast, actually. The gentleman said, and I told him I was in recovery. And he said, they didn't really treat me any different. I said, well, it's a pretty big risk on a lot of people's parts. Well, now you've got very clear data for the team to focus on the right things. And you don't have to probably do much more work. It's just having resources available. So we're going to also work on that with this particular system we're working with on how we look into that. But yeah, it's a very, very, very large number where it's very much of a vanilla approach to that process, unfortunately.
I'm curious because, from your perspective, you saw a problem, you identified an opportunity to deliver a tool to the market, and these things aren't, you're not opening a Subway sandwich store. Like, there is so much more that goes into these healthcare technology businesses. What is some of the most frustrating things you've run into in the life of Thrive Genetics?
I think frustrating comes in different flavors, right?
Mm-hmm.
Um, I think part of it is like there's a couple different answers to that, and I'll try and keep this brief but colorful. Meaning, I use the analogy of being a skier, and I'm not a skier, but or a hockey player where you're looking at the net, not looking at the goalie. You're not shooting the puck at the goalie, or you're not skiing to look at the tree. You're trying to find the white space, whether it's the net or the snow. And in healthcare, I think we tend to be looking at the tree, or we tend to be looking at the goalie, and we're not putting the puck or our skis in the right place because we're immediately recognizing I cannot do that. I actually teach innovation, and one of the things I do is a little bit of a triangle where I say, you've got your idea, you've got your action, and you've got your impact. To go from idea to action, there's a lot of people saying, you can't do that. That doesn't work. That doesn't work here. So-and-so is going to block that. This isn't going to fly. There's a regulation for that. There's a regulation for that. Do you have a CPT code? And then you start checking off everything that you can't do. You may as well just go home, right? Let's just
Right.
go take a nap because nothing's going to work here. And I think the biggest problem with that is you're looking at the tree or you're looking at the goal. We're not looking at the opportunity and where it fits. And I think it takes some experience, unfortunately, to learn the hard way as to what doesn't work. And I'll give you an example of what doesn't work. A lot of startups fail at EMR integration when they have this great idea and they say, I'm going to stick it into the workflow of the doctor and that physician's definitely going to use it. And the physician's like, I'm not using this. And the IT department's saying, go home because you're not touching my Epic system. Those are all the roadblocks you're going to find. So the question is how do you do something that is simple? How do you take a less complex approach? Do you need to include your API to Epic, or can you just send a PDF or a text to an email and then the physician attaches it? There's so many complex things that we tend to like really look at the trees. So to me, that's the biggest thing that I see as a complexity in healthcare in general, and I don't think that's news. Um, but that's it's a little bit of extra time you have to take to listen and to ask the questions and to understand. Each system is different, and how do you slightly nuance that? And I think we all know that too, but it just takes a little bit extra time and creativity. I often like to play into the room a bit and say, okay, is this even the right place to do this? Because I've actually had calls with customers, and a customer would just say, you know what, no, we don't do this here. It's like, okay, that's okay. We can do this somewhere else, right? It doesn't have to be done here, right? I'm not trying to sell anything. I'm trying to figure out the best possible way for us to achieve a goal together. And sometimes, there has to be some human synergy there. It's not just, a transaction. There has to be a human synergy. I can't, underline that enough with who we work with. Absolutely.
It seems like, the experience is this inertia of engineering, meaning there's this massive engineering on the front end in all medical device of every kind. And there's magic in that engineering, right? To get to the same. But unfortunately, the inertia of engineering keeps going as we try to go to market. And now we're over engineering a time when we should be simplifying. I don't know if that makes sense.
It does. So in 2003, I don't know, it was 2002, 2003, 2002 and 2003, I was on a committee with the FDA on 21 CFR Part 11. And every month for about 2 years, we would get together with the leaders of that group. And I was sat with every pharmaceutical company at this big, big table. It was like, I call it the Dr. Evil table from that movie from a long time ago.
Yeah.
Everyone sit around the table and we would just talk about the interpretation of the rule. And we would go in circles for hours, weeks, months. And everyone would voice their opinion. Well, this is what we're doing. This is how we're doing it. This isn't right. This doesn't work. What does this word mean in the regulation? And that was the classic just staring at the tree. It was a classic moment. I said, wow, this is eye-opening. And we were all doing the right thing. And we all wanted to do the right thing. But we didn't step back out of it and say,
Yeah.
really, what are we trying to accomplish here? And how are we trying to create a better world and a better experience for the patient? Or in this case, for Part 11, it was a little bit more about product development. But so it was very interesting to see that. And, you have to kind of turn the switch and turn the dial a little bit. And sometimes, ask questions that are uncomfortable. And the regulatory environment of a medical device should be what it is. My daughter has a medical device. She had it put in her when she was born. And I'm not joking with you. I still have the card and the company, I won't name it, and I still hold it dear to my heart. So medical devices and the stringent regulatory approach that we go through, I am 100% in favor of. I
Yeah.
could not agree more. And I love what we're doing in our country and the way we manage our patients and our products. And, so I'm in full support of that. But the question is as we go down, these cycles, are we looking at these things properly? some of that won't ever change, and some of it can be influenced, I think by quality product design.
Well, I think, the visual that comes to my mind is I'm imagining this huge field and we're trying to get to the other side of a field. There's a single door in the field. We're walking up to the door and it's locked. So we turn around and go back, as opposed to like there's
Yeah.
other approaches, right? And that's what it feels like you're talking about. When you're teaching innovation, are there any tips or frameworks that you use to help someone try to create that outside view for themselves so that they are like taking a step back and looking from a broader position?
So I think the easiest answer for that is, if you, and this is oversimplifying it, and I think some people might, run either direction with this. If you really take a step back and you go back to the root of why you did anything,
Mm,
like, why did I do this company? Because I recognize that we didn't have a way to understand addiction. We're guessing. There's a gap in care. We're saying maybe this person who's coming into my office who's going to get radiation oncology, maybe they have an addiction, maybe they don't. I don't know. Here's the medication. Good, thanks. It's a guessing game. In this day and age, why on earth would we guess at prescription uh, narcotics that are prescribed in this way? Why would we guess? How do you possibly? There's no data, really. So I literally took that to heart. Now, when I'm in the trenches and people are saying no all the time, and I'm getting beat up every day, which is, that's what a startup founder does, right?
yep.
That's my job. Um, the point of everything I do has to go back to that first moment of conception of this company. So when you're sitting and thinking about innovation, okay, and I'll put my money where my mouth is. I worked for SAP for 15 years. Okay, I spent 10 years in startup, 15 years in corporate, and then I'm here for 3. When I was at SAP, I spent plenty of time pushing the envelope. People would say no, and my key to success was putting metrics behind everything to show improvement. And they had to be real, true metrics. So I would say, okay, you want to go from point A to point B, but you're saying no, 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 no. That's okay. I understand. First guy says no. Why? Well, he's kind of in closer to retirement, is not interested in moving the ball. Okay. Person number 2 was young but has no idea. And I'm going through all the age groups to be fair to
Hmm.
everybody. The guy in the middle is a hustler, or she's a hustler and wants to move the ball. Okay. Let's focus on Amy. She's in the middle. Okay. And you have to work with those folks who want to do the right thing. And it can get blocked at the executive level for reasons maybe you don't know. But if you have the data and you have the support and you're able to create a team behind that idea to go from idea to action, that is a very formulaic way to do it. And every culture and every corporation is going to be different. I think taking this out of medical device and just into innovation, normally you want to look at it in a way that you create your success with a team of people and data. That's the short answer. Lots of data to support your decision, metrics, and people. So it's just like, when you're building a startup too, you have to have, finance and capital, and you have to have the right people to build the company. It's very, very similar.
You know, the way our brains are wired, it's so easy to go down the path of no because there's tremendous comfort there. There really is. For most people, there's a lot of comfort in saying something can't be done because we get to reduce risk. I get to be right because we didn't try it. So since we didn't try it and I said we couldn't be done, I was right. We're not doing it. And it's about finding, I think, like you said, that culture that we have to do things for the right reason. We have to have that underlying why, and we can't make things up, but we also need to challenge our own brain's desire for the comfort of no, because what is comfortable for our brain doesn't necessarily mean it's good for us.
Yeah. So it's interesting about the no. And I just said this the other day, and I'm going to say it here too. No to me was the greatest insult 10, 15, 20 years ago. I was like, no? Oh, what? And then as I started to like listen to what people would say, I would say, okay, instead of just getting in my own ego, I said, let me put my ego over there, get rid of my ego for a second. And I go, wait a minute. No. Oh, okay. Why? And they would say, well, blah, 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 blah. Okay. 9 out of 10 things that person just said mean nothing to me, but there's
Yep.
one golden nugget in every no.
Yeah.
Then I started to track this and I was like, oh, this is really interesting. Now I'm like a no freak. Like, I love no. Give me no. This is the greatest answer I can possibly get from you. I don't want a yes. I want the no. Because once I get the no, then I could start writing down. John said no out of his 10 things. This was a golden nugget. Stacy said no. Here's her 10 things. There's her golden nugget. And I take each golden
Beautiful.
nugget from the 10 people I talked to that said no, and I change. I alter. I structure differently. I create a different product. I create a different pitch. I create a different method. I pivot my company, which I've done several times, to a different market, maybe. And then you start to collect the no's and go, this is the greatest gift you've ever given me. And I could be in a meeting with somebody and they said, that guy was really mean to you. I said, that was a great meeting. They're like, what do
Yeah.
you mean? He said no. And he was not only that, he was rude. I said, that's just like human stuff.
Yeah.
There was gold in this no. And I pulled it out. And it was like it was like made my day, right? And because it makes you think. And if you go back to Thomas Edison, when he did what he did, and the brilliance that came out of his lab, and if you've never been there, it's a beautiful experience to go to his lab in New Jersey. It's so inspiring because there's so much there. And you got, how many no's did this guy get to do this? It's so inspiring. And I love that. J&J's right there. There's a lot of farmers right in the corridor there. If you're ever in that part of New Jersey, it's well worth a visit. But I love the fact that you can grab so much gold from a no. So I think if you're open to put your ego aside and your personality at rest of it, and it's tough in corporate because it's a little bit harder, obviously. Um, you can gain a lot of knowledge from the no's. It's just a gold mine sitting there waiting to happen.
There's a lot of wisdom there. That is so true. Very well said. Well, James, I really appreciate you taking the time and spending it with us. If the audience wants to connect with you to learn more, is it okay if they reach out to you through LinkedIn?
Yeah, James Piacentino. I think I'm James J. Piacentino on LinkedIn, but that's great.
Okay, and we'll put that link in the show notes. This is definitely a company I'll be following. It's really fascinating, powerful what you've done. Congratulations of where you brought it, and I'm excited for the future.
Thanks, Zed. This is incredible. I appreciate your time in doing this.
Absolutely. And we'll see you next time on the Medical Sales Accelerator Podcast.